Welcome to our debriefing toolbox. So now this is number one out of the two sessions within this toolbox that we're going to go through about debriefing, how to do it. And basically this toolbox will be about the theory behind the practice. So please remember, you will need to apply the learnings from today into the practical simulation for next week. So listen carefully. But this is our four people that will be presenting. There's me, Annie, and then there's Nadine.
Hi.
And Simon.
Hi, everyone.
And Kelly.
Hi.
All right, so we'll go on to the acknowledgement of the country. So we acknowledge that we are situated on Noongar land and that Noongar people remain the spiritual and cultural custodians of their land and continue to practice their values, languages, beliefs, and knowledge. We pay our respect to the traditional owners of the lands on which we live and work across Western Australia and Australia. All right, so since we're talking about a little bit of a heavier topic today, we're going to give a little bit of content warning. So here are some resources if you need to contact anybody after our education, but feel free to drop out at any time if you're feeling uncomfortable. And of course, contact any of us if you want to have a chat about what's been happening. All right, so it seems like we're all right. We're doing okay here. So we'll continue to the next slide. All right, so now talking about an icebreaker, I think it's a pretty serious topic we'll be talking about, and it's quite sensitive. I think it's good if we get to know all of us and get to know about each other. So this game will introduce ourselves, introduce our name, and describe the job that we do to explain it in a way it's to a 5-year-old. So I can go first. That was some really good comments I've heard from everybody. It's quite funny to see where we all work, and it's funny to see it in a description for a 5-year-old. Well done, guys. So now we'll go through the learning objective for this lesson, and that can sort of round off what we want to talk about. All right, so we'll start with some definitions first. Can I get everybody to scan this barcode and tell me what is debriefing to you? So I'll give you guys a couple of minutes to do that. So I want you to scan the barcode, or otherwise you can just join us from that little website thing I've put on the bottom and use that code. This way we can actually display everybody's answers and see what you guys come up with. All right, so let's have a look to see what we all come up with. Yeah, there's some really good answers. So I'll pop up what we got on the screen so far. All right, so we've got a couple of things. Yep, I can see that somebody's wrote hospital stack 1. Yes, that's definitely something we should be debriefing on. There's something about improved performance. That's really good. Good work, guys. You've come up with lots of good points on describing what debriefing is. I can see that somebody's wrote psychological first aid. So it's probably good if I address this as well. So the thing is, psychological first aid is sort of an element of debriefing, but it's actually not debriefing itself. Debriefing itself, it can contribute to psychological first aid, but it's not something that can replace it. Psychological first aid, I want to think of it as more of like a therapeutic thing where, you know, it's an ongoing mental health management rather than debriefing just to cover what's been happening. I've got this really good quote, I thought, that you would like to see about debriefing. So the definition of debriefing, so it's reflecting on complex decisions and behaviors of professionals, compete with confrontation of ego, professional identity, judgment, emotion, and culture. There will be no substitute for skilled human beings facilitating an in-depth conversation by their equally human peers. So that's a pretty nice quote. It's sort of philosophical. I think that's how debriefing is. It's about humans, you know, how we work together as well. All right, so a bit more about definition of clinical debriefing. So it is a systematic discussion among individuals after sharing the same experience during patient care. So this is more so debriefing in terms of clinical and, you know, as healthcare professionals. So there's a few points about debriefing over here. It uncovers insights and generate ideas to improve together. Like any skills, debriefing requires training and practice. So we'll have to keep practicing in order to get better at it. So when we think of debriefing, so we need to think about what are the purpose we're doing it. So debriefing intentions, there's a couple of intentions I've listed over here: to manage, to learn, and to treat. So I won't go over it too much, as Nadine later on will probably brush on it a little bit more. So often all of these actually goes together. It's used in a variety of ways. I want you to think about these intentions during previous debriefing experience that you've had yourself. What was it for, and what do you think it was intended to do? So critical incidents, any event that is significant enough to overwhelm the person's normal coping mechanism. it is actually defined by the person experiencing the event. It could be something that's not traumatic to you, but it is really traumatic to somebody else. So you can't think of it as, wow, that's a really bad incident. I'm very affected by it. Doesn't mean your peers are, or it doesn't mean your peers are not. And you can feel these things immediately or even in the future. So debriefing itself for critical incidents, I won't go over it too much, as Nadine will also cover this little section as well, that recently sometimes it's used more like a quality improvement project as well in hospitals. In particular, where I work, we're going through looking at critical incidents in terms of managing patient falls. So we debriefed after a scenario where a patient had a really bad fall because a bed rails were put up. And after debriefing that incident, we realized bed rails are actually causing the patient to have more severe falls. Therefore, that implemented like a quality improvement project where we kind of looked through how many incidents has happened because of it. And, by looking at these data, we can look back on how we can improve practice. Just a way of how debriefing contributes to critical incidents. So individually, there's some self-reflective practice going on, which is important as healthcare professionals. We should always look back at our own practice and what we're doing well and what we're doing not. And this helps with lifelong learning. All right. So now just a little scenario for you as well. There's this case where imagine if you're a nurse and you had to look after a patient with a chest drain, but you're really uncomfortable with that chest drain. You've actually put your hands up and said, oh, I'm really uncomfortable with this. Can somebody help me with it? So even though you've said that you're uncomfortable with it, you were still kind of put in a position where you end up having to look after the patient. Then a critical incident happened because of this. A patient actually ended up getting a pneumothorax because improper management and ended up in ICU. So now at the debriefing, what do you think should happen? Should we be blaming the nurse or should we be looking at all attributes of it? We need to think about things like this when it comes to debriefing. It's not a session to blame somebody. It's actually just to look at all of it, what's been happening to cause this outcome and how we can do better next time. All right, a bit more on hot and cold debriefing. So this is more so like when you do it. This occurs at various stages following the incident. So hot is immediately after, led by a facilitator. They may not be trained, but preferably trained. Could be somebody like the consultant that led the resus. And hopefully everybody is all present at that time. So this is a brief recall of event and debrief. So talk about our feelings, talk about what's happened in the event. And cold debriefing itself, it's more like a delayed discussion led by a trained facilitator. Usually this is booked ahead of schedule and everybody needs to be there, and plus external guests, people that might not have been in that actual scenario, let's say radiographers, and maybe paramedics as well. They're a part of it, but they weren't involved. It's good to have them there so they can also talk about what has happened. And this cold aspect is more so where that quality improvement initiative happens. All right. So now I'll invite Kelly to talk about challenges that may occur in debriefing.
Challenges to debriefing. Debriefing poses several challenges, including timing constraints. For example, determining when the team can convene post-incident is crucial. Factors such as the availability of key participants can greatly influence this timing, and given that many of us healthcare workers are shift workers and have days off and leave, arranging a suitable roster for attendance can be quite challenging. Additionally, in the case of multi-agency debriefs, it's important to assess if the involved organisations actually support the process and are willing to release their staff to participate at a suitable time. For the environment, the physical setting significantly influences the effectiveness of clinical debriefs. If a participant perceives potential interruptions or the risk of others overhearing, it can compromise the integrity of the entire process. Sometimes not all participants can be physically present and may need to join remotely. And in such cases, the room should be appropriately equipped with the right technology, including a screen visible to all in-person attendees and a camera that enables the online participants to observe the room. This type of setup can allow the online participant to recognise the non-verbal cues and ensures that remote participants remain engaged and feel included in the discussion. The workplace or team culture also plays a significant role in success. In environments that are characterised by a culture of learning and self-reflection, debriefing tends to be highly effective. Conversely, in dysfunctional teams where discontent is prevalent and communication is poor, critical incidents may occur more frequently and successful debriefing becomes challenging. Some teams or organisations may foster a blame culture where employees are hesitant to disclose errors due to fear of repercussions and disadvantages. This type of fear can inhibit an open discussion and hinder the effectiveness of the entire debriefing process. The suitability of a facilitator for specific debriefs can be influenced by their education and experience. Effective facilitators require both training and sufficient preparation time to confidently lead a debriefing session. An experienced facilitator may not always be available on site and may need to join remotely, which can, in some cases, reduce participation and cause a feeling of disconnect. Facilitators need to employ active listening skills and know when to speak and when to allow participants time to process information. They need to use 2 ears and 1 mouth and not dominate conversations. They also need to possess the ability to diffuse arguments or calm individuals who may be experiencing anger or distress while still acknowledging their emotions. Also important for a facilitator to understand the clinical aspects of the incident so that they can comprehend the participants' questions and their statements effectively. Information is incomplete, it can significantly undermine the effectiveness of the debrief. Facilitators must ensure that they have access to all pertinent information before the debrief occurs, which may involve liaising with the key participants to verify facts and gather additional details. This type of thorough preparation can ensure that the debriefing process is based on accurate and comprehensive information and enables for a more insightful analysis and discussion. Conflict within the workplace can hinder effectiveness of the debriefing process, whether it existed beforehand or arose from the critical event itself. In such cases, it may be beneficial for facilitators to hold a preliminary meeting with the conflicting parties to mediate and help them address their underlying issues. These pre-debrief meetings can also clarify the behavioural expectations for the debriefing session, fostering a more conducive environment for constructive dialogue and resolution. Despite thorough preparation and positive intentions, participants may sometimes exhibit behaviours that hinder the success of the debriefing process. Instances where certain individuals dominate conversations, veer off topic, or display disrespectful behaviour towards others or the debriefing process itself can interrupt the session. Such behaviours may lead others to disengage or shut down, making it challenging to maintain a productive participation. Re-engaging or salvaging the debrief in such circumstances can be quite a formidable task.
All right, well, thank you, Kelly. So now let's have a break from that heavy topic we just spoken about. So refer to those pre-reading articles, guys, that we got you guys to read. There's 3 of them we've picked out specifically for this class. So based on these readings, can you guys form into 2 groups? We've got group A on the left side of the class. You guys can talk about why debriefing is good, why we should do it after a situation, after any sort of clinical incident. And on the left side, let's talk about why debriefing is bad, why it's a bad thing to do. All right, so I'll give you guys a couple of minutes to do that. So we've got 5 minutes. I'll put a timer on there. I want to hear all your thoughts. All right, okay.
I heard a lot of different ideas and different debates, topics on why debriefing is good or bad. So we're just going to step back for a second to have a look at some of the evidence that's surrounding debriefing. It all makes sense and it sounds good, but in a evidence-based world, what does the evidence actually say? So what does the evidence say about debriefing post sort of critical incidents? Funny enough, not just healthcare workers need debriefing. Many other fields of work involve critical incidents. We talked about war, we talked about working in the emergency department, but firefighters, first responders, police, and obviously after so traumatic incidents, for example, 9/11, and even sort of natural disasters, tornado, flooding, when people are completely overwhelmed and their sort of physiological defense mechanisms break down and can't deal with the stress that we see, PTSD and debriefing come into play. What is the state of play for doctors? And why do we as sort of healthcare workers care about critical incidents? In 2014, studies on what happens when a doctor makes an error. And they interviewed about 57 doctors in the month following the error. What they found was sort of about 50% of them described feelings of guilt and shame. 25% or so 1 in 4, feared for the patient itself. And about 1 in 3 reported a loss of confidence. And 1 in 5 found themselves questioning their own competence at a professional level. And sort of more interesting and sort of, something to highlight is that 30% of doctors within the month of making an error started questioning themselves. They sort of avoided responsibility. And you can imagine how that ends up, at the detriment of sort of good patient care. The impact of perioperative, incidents on anesthesiologists after a national survey, they show that sort of 20% of anesthetists acknowledged having never fully recovered from an incident that's happened to them. 1 in 10 considered a career change, and only 7% of them received sort of time off. So you can imagine, 1 in 10 people was given time off. 1 in 9 had to go back to work the following day after what they considered a catastrophic incident. So we all know that, critical incidents affects every one of us. So in the 1970s and 80s and the 90s, when all this was picking up, Jeffrey Mitchell, one of the healthcare worker working in an emergency, along with George, published this paper in 1993. It's regarded as one of the most widely cited papers looking at sort of critical incident and stress debriefing within sort of different high-risk occupational groups. So they developed a 7-step framework on how to provide sort of debriefing after critical incidents, looking at various aspects. And this sort of model, it's called the Mitchell model, still prevails today. Well, we've looked at some of the evidence, we've looked at some of the methods, and Annie has given an introduction. Does it actually work? We got to ask ourselves for what. It depends on what you mean by work, because the the details, devil's in the details, right? Critics point to the number of hazards to the Mitchell model and to debrief in general. For example, there are no actually high-quality randomized, controlled trials comparing having debrief versus no debriefing. Some critics think that stirring up the pot may worsen trauma. As Kelly said, different people deal with the critical incidents differently. And so, not one size does not fit all for everyone. Someone that feels like they're overwhelmed for one person might not be the same case for someone else. And so, we need to be very careful and sort of, when we talk about the debrief, how to use the same debriefing strategies to apply to different fields and to different individuals. So looking at some sort of big studies, for psychological safeties in general trauma, so not just medical trauma, just trauma in general. Cochrane Library reviewed a Cochrane review, so a systematic and meta-analysis. What they actually looked at was that, single session debriefings did not prevent the onset of PTSD, did not reduce psychological distress compared to control. And also, there's sort of no evidence that debriefing reduces general physiological morbidity, depression, anxiety, or that it was superior to educational intervention. Obviously, this was done about 14 years ago, and since then there's been multiple other studies and multiple improvements along that in that area. How about psychological safety in emergency responders? Multiple studies from multiple different papers looked at psychological safety in first responders, and they all came to a conclusion that sometimes inappropriate debriefing can cause more harm than good. In firefighters, they looked at group debriefing. They showed that reduced alcohol use compared to placebo, so no debriefing at all. There was an increase in quality of life compared to sort of educational programs, one of the 3 branches of their sort of intervention. But once again, they stressed that single sessions individual debriefing did not work. A little bit closer to home, there's work in first responders. In 2020, King's College in London published a 200-page review. They showed that there was considerable variations in practice and supportive research resources around the United Kingdom. And the majority of wellbeing support avenues had no strong research backing. So it's a bit of a worry, isn't it? They did find that prevention and resiliency training is better than actual treatment in terms of using debrief as a sole tool for PTSD. TRIM, which is a model of sort of debriefing, which I think Nadine would talk more later on, does reduce sickness absence and PTSD syndromes. And sort of the critical incident stress debriefing sort of thing, they've noticed that individuals with high levels of arousal may be put in a heightened risk for poor outcomes. So, once again, the critics were saying, do you want to stir the pot after a critical incident has happened? Standalone strategy may make the PTSD more likely. And the NICE guidelines, the National United Kingdom self guidelines, recommend against use of a psychological focused interventions instead of actually preferring offer the opportunity, watch and wait. Lastly, there's a work of healthcare workers specifically. A comprehensive review published last year looking at the evidence behind debriefing and well-being emotions for healthcare workers. They pointed out sort of there's two big categories of purposes, which Annie alluded to earlier on. First is for well-being, PTSD, and mental health, and we have those two models. But more importantly, the value of debriefing in learning and performance improvements, and they have various sort of frameworks and reflect, talk, and pearls. Once again, they pointed out single sessions without follow-up is detrimental. Having a system-wide and consistent support for your healthcare workers that have gone through a critical incident is more beneficial than a single debrief session. They've noted that the TRIM model may be less detrimental because they actually don't require a participant to talk about the details of the event. And finally, sort of strong peer support, informal debrief, and sort of cold debriefing after the fact over the last 40 years is out there, but it is very complicated and the evidence is conflicting. So I think the key is to make sure that you have set and defined goals and aims when you do a debrief. You want to focus on the specifics in order to get the benefits of having a debrief after critical incidents.
Basically, might not work for everybody. There's intention to treat and intention to learn. We're going to focus on intention to learn because that's where most of the evidence is. And it may not just need one session. People might need more sessions and more support. But just keeping this in mind, what we want to talk about that now is how to debrief. Okay, so we want to debrief well. We want to make sure we don't cause any harm. So how do we debrief well? Okay, so first of all, we're going to do a group activity. So are you going to go into pairs or groups of threes, please? Together, brainstorm about what you think is important in debriefing. So 3 key principles of debriefing. Choose the most important one, and one of you will come up to the whiteboard and write it down. Okay, so guys, go ahead. You got a few minutes. All right, now come on to whiteboard. Who's first? Susan? Okay, great. So what's important to you in debriefing? Voluntary. Good. So debriefs are voluntary. People need to feel comfortable and safe to participate. And if someone chooses not to come, that's completely okay. And the debrief proceeds. Okay. You can't force anyone. Mike? Straight after the critical event. Okay, so good. That's what we call a hot debrief. And that's mostly what we're going to talk about in this next bit. Jacinta, what did you guys have 5 days after the critical incident, right? So you may choose to do a core debrief a few days later. The process and structure is slightly different, and we're not going to talk too much about it, but also very, very important. Abraham, what have you got? Events, facts, great. So you need to have a factual conversation of what's happened. Focus on specific content, individual team performance, processes or systems. Make sure accurate information is discussed. And that's a really good reason why the person leading the debrief needs to have a good awareness of the situation and what's happened. Elijah, what have you got? Process issues. Okay. So part of the point of debriefing is to look at the processes that went well and those that could improve. And that's part of, the learning. Very, very important. Angela, only people directly involved. Good. Yes. For a hot debrief, you only want the people who are directly involved in the event or situation. This is not the place for executive. This is not a place for voyeurs. It could challenge the psychological safety of those who want to debrief. Now, in core debrief, you might want to have other stakeholders, as was discussed by Annie and Callie before. Vanda, what have you got? Planning to do better for next time. Great. Very important point. Really important. Intention to learn, intention to do better in debriefing. The idea is to address specifically what can be improved in the next situation on an individual or team performance level. Aisha, emotions. Good. So as part of your psychological first aid discussion, emotions can normalize them. Normal to have a wide range of emotional responses, just like we said earlier. And then if you have persistent intrusive thoughts or someone in the team seems to be quite affected, you need to make sure they speak to their supervisor or, employee assistance program, lots of support out there. Good. So as a group, we've come up to those 4 principles. Key principles in debriefing: voluntary participation. Make sure you talk about the facts, talk about the feelings, and planning for the next time. Right. Well, I just want to go through a couple more points. Okay. So first of all, we've talked about who comes to the debrief. Everyone's invited. No one forced to come. Who leads the debrief? So really important. The leader of the debrief needs to have emotional intelligence, compassion, no judgment. They need to be able to have objectivity, including to their own performance. They need to be able to facilitate a team discussion, encourage open discussions, maintaining psychological safety for the team, no blame culture, and be able to manage conflicts if it arises. Now, if the team leader of the resuscitation feels themselves affected too much, then they might not be able to lead the debrief. So you might need to delegate that to someone else. Often a very senior nursing member can also take over. And if they're scribing, then they may have a little bit more of a situational awareness, but a bit more of a space and be able to do that. So they're usually really good at that. When do we do a hot debrief? So a hot debrief is as soon as possible after the event. And just like Callie said, we're all busy, we're all shift workers, might not happen, easily. So you really want to try to do a hot debrief in the same shift, and a cold debrief trying to get all these people together can be quite challenging a few days later, where you need to have it in a private and confidential space, and preferably a bit far from where the event happened, just to get that cognitive space. And finally, how do we debrief? So have you guys heard of the plus delta method? Yeah, so very commonly used method, involves group discussion on what went well, what should be changed or improved for the next time. So it's a really easy way to learn and implement. It does have a few faults. So you may have an inexperienced debriefer that lets it turn into blame game, finger pointing, tangential discussions, or some, leave out members altogether. So really, ideally, is you have a team leader who's educated and practiced on the art and science of leading a team debrief. And they can use tools to help have a structure and format to your debrief. There are many debrief tools. Today, we're going to talk about 4, and we're going to talk about them very quickly. And then you will have the chance to practice them in our next workshop. All right, so Talk. Talk was developed by a group of anaesthetists in the UK, published in 2021. The development of this tool involved clinicians, academics, quality improvement experts, and psychologists, and later even included international experts, adding the layer of awareness of cultural differences. As the name goes, Talk focuses on the importance of dialogue and positive communication strategies, and emphasizes on team communication and an inclusive culture, which we all know is paramount to patient safety. So the idea is that clinicians share reflective conversations, exploring how to improve or repeat successful performance, and empowers them to take responsibility for acting on these reflections. And what I found really interesting is the group made a point of reflecting on both the good and the not so good. So broadening our focus from safety 1 to safety 2 approaches, safety 1 focusing on learning from risk and failure, and safety 2 understanding what and why went well. As you can see, the talk structure consists of 4 steps: target, analysis, learning points, and key action. The first point of target is, as a team, you choose and you agree on what is important to discuss. During analysis, team members discuss how to repeat the successful outcomes or identify areas of improvement, and they suggest improvement actions. Learning and key actions. Team members agree on solutions and take responsibility and individual accountability for following up on these actions. So what are we going to do? Who's going to do it? How are we going to do it? How are we going to know it's done? Okay. And that last step creates purpose and engagement and adds value to this, the time invested in the shared reflection. Talk has a few videos. This is one of them, and it just goes for a little bit, like a minute.
Talk is a structure that guides a learning conversation between team members following a case or clinical session. This dialogue is called clinical debriefing. It should be a short, focused discussion lasting no more than 10 minutes. It could take place immediately after a case, at the end of a clinical session, or later at a suitable time. Having a talk conversation may be useful following good outcomes after difficult cases, when team members are exposed to new clinical experiences, after near misses or serious untoward events, or in other situations. Talk gives a structure to the discussion so that it is carried out constructively and focused on a common.
I'm going to stop there. There's plenty of videos on Talk, actually. So if you're interested, I'd suggest you go look them up. The next tool is Reflect. So that's a group of American pediatric emergency and intensive care doctors with significant experience in debriefing that looked at recurrent themes in debriefing in the literature and then developed Reflect. As you can read, it's an acronym, and that is a little card that they laminated and put in their little pocket. And it was fellows, pediatric emergency medicine fellows tried it and felt that it provided a succinct structured framework. Stop 5. So that tool was developed by a group of emergency doctors in the UK, published in 2020. And the aim of this study was to design, test, and develop a hot debriefing tool that was quick and easy for any staff member to use, and that could be used to facilitate safer patient care, team development, and quality improvement in the ED. So in 2017, they established a focus group consisting of emergency consultants and registrars, senior staff nurses, simulation leaders, and they reviewed existing models, looking at research literature and frameworks in other clinical contexts. And then they divided into little teams, and each team's made a little framework, and then they came together again and finally made Stop 5. And the idea is that any member of the resuscitation can lead a hot debrief. The leader initially thanks the full team and asks, is everyone okay? If yes, they continue and read out a series of statements. As you can read them, we're going to have a 5-minute debrief. Purpose is to improve quality of patient care. It's not a blaming session. Your participation is welcome but not compulsory. All information discussed during this debrief is confidential. And then afterwards, they do summarize the case, things that went well, opportunities to improve, and points to action responsibilities. And they record everything on a data collection form. And in multiple quantitative and qualitative analysis, it's shown to be very effective. That's through staff surveys, analysis of debrief recordings for audit purposes, analysis of data collection forms, and actually looking at system improvement form. So really, Stop 5 is a rapid, easy to use, effective model for a busy ED setting. And finally, I'm going to talk about the IRAS framework. So that's developed from the Australian and New Zealand College of Anaesthetists and published in 2021. It's 6 phases. I find it interesting that it's, out of all the models that I looked at, it has a reaction phase, which is when we talk about the emotions. But otherwise, it's similar. So the introduction and intention is we're here to learn. Everyone has introduced themselves. It's voluntary. There's the rules of engagement of confidentiality, mindful language, non-judgmental, kind and compassionate. And the idea is to acknowledge that this was potentially a difficult or confronting case. Reaction phase about the initial reactions and the emotions, and talking about how those emotions are normal, a varied range of emotions are normal. Analysis of what went well and what could be improved in terms of decision-making, communication, teamwork, technical skills. Could use a plus delta for that. Make sure you keep on time. Summary phase, take-home phase. In part of the take-home phase, they talk about if there are issues raised that need to be resolved outside of the debrief, who will do what, and give individual accountability and responsibility. And a thank you phase. So I really like that bit. Thank you for doing what you do. Thank you for being in the debrief. Reminding rules of confidentiality. Talking about a future core debrief as required. So a really good model. Now, if I had to choose my favorite model, then I would, before I tell you that, you guys have to think about, for the next workshop, what model you like, what model comes to you intuitively, because they're similar but different. And what you're going to practice, we're going to get a chance to practice a few, but think about, potentially what you would like. And then as you practice, you might decide that you prefer another model. I prefer the Stop 5. I think for me, working in a very busy ED, it's very clear that it's only going to take 5 minutes, and therefore you're going to have more buy-in and engagement. And it's also very simple, and we like simple. So that is it from a model's point of view. So in conclusion, we've had a really good discussion on what is a clinical debrief, why we debrief, how we debrief, and different models of debriefing. So thank you so much, Annie, Simon, and Callie. And what we'll do is we're going to leave our details here. If you guys have any questions now, you can ask them. If you have a question later, don't hesitate to find us or email us. Any questions? No? Okay, great. What we would like is to make, we always want to do better and improve. So if you could scan this QR code and give us evaluation, let us know how you thought the talk went. And we'll see you at our next workshop where you get to do some practicing. Okay, so here are the references. Bye.
for joining us. Looking forward to seeing you next week.